everybody, and welcome to this live webinar focused on the updated guidelines for the management of intermediate hyperglycemia. And I think that Professor Colagiuri will clarify this new concept that introduced by WHO and the type 2 diabetes. For me, it's really let's introduce myself. I'm Antonio Ceriello. I'm the research consultant at the Multimedica Research Institute Multimedica in Milan. And okay, these are my disclosure. And let's also say the role of MEDEA, because the Medical Education Academy that is a global medical education, and was taking care of the contents and also the organization of this webinar, as well of other activities, because this live webinar will be the first event of this project. And then we will have some podcasts and infographic, which will be launched in September and October, respectively, and a video interview in November. So we will cover different aspects of the topic. We have the endorsement of several bodies, scientific bodies, as you see here, and this, in my opinion, qualifies even more our activity. We have already 267 participants from 24 countries, but because this will be freely available on the website, I think that many other people will be engaged later on the activity. This is an international committee of MEDEA, and but let me spend a few words about the faculty. We have really the pleasure to have with us Professor Stephen Colagiuri from Sydney and Professor Linong Ji from Peking. They really represent the two top speakers, but also they were widely involved, as we will see, in the development of these guidelines, both for the global, but more specifically Professor Linong Ji for some guidelines related to Asia, which is, of course, particular and different from other regions. What are the objectives of this webinar? We have a knowledge of the 2025 updated Global International Federation guidance and know the new guidance for Southeast Asia primary prevention of intermediate hyperglycemia. So we will cover the global with Professor Colagiuri, and more specifically the Southeast Asia recommendations, which of course are specific for this part of the world. This is the agenda. My brief introduction, which will stop soon, and then we will have Professor Colagiuri, who will present the global IDF price recommendation, and then Professor Linong, the South Asian primary prevention, the guidelines again. And then we will have a debate and panel discussion that you are all invited to send your questions that we will try to address during our debate. So the activity is accredited and by the European Accreditation Council and is with, with one CME, and this program has been certified by the CTD certification service. So you can get the CME from. To get the certificate, please complete the participant evaluation form at the end of the webinar, and then you will receive by email the certificate. We have a simultaneous translation from English to Spanish and Chinese. And when after each lecture, I think the best choice, please submit your question to the lecture in the question and answer section, and then we will try, as I already anticipated, to answer your question. So, and finally, let's thank Merck Healthcare for sponsoring this activity, and I think it's time to start. Professor Colagiuri, please.
Sure. Okay. Okay. So thank you very much, Antonio, and for the opportunity to participate in this webinar. I do have to apologize at the beginning because I'm recovering from an upper respiratory tract infection and my voice is a bit croaky and maybe an issue during this presentation. So I'm going to talk about the, sorry, I'm going to talk about the IDF clinical recommendations, and I need to declare that I don't have any personal declarations, but I do need to acknowledge that these development of these recommendations was supported by an educational grant from Sanofi and Servier, but these companies had nothing to do with the development of the recommendations. And as you know, I'm here to try and just tell you a bit about these guidelines, which you hopefully will already have seen and which you might find useful. There are a lot of people involved with producing these recommendations. There was a group of people who were called contributors, and there were also a number of external reviewers, and the whole process was co-chaired by Professor Ceriello and myself. The target audience for these recommendations are all healthcare professionals who manage people with type 2 diabetes and those at risk of developing type 2 diabetes, but also policymakers to try and encourage them to provide the healthcare and the healthcare system reforms which are necessary in order to be able to implement these recommendations. Now, we all know that type 2 diabetes is a major global health challenge, and in order to meet this challenge, it requires a comprehensive, integrated, and person-centered approach that is supported by a health system which focuses on chronic care. The reason for doing them at this stage is that the last IDF guidelines and recommendations were produced 20 years ago, and since that time, there have been a lot of advances, new medications, evolution of diagnostic tests, and also a number of technological innovations such as continuous glucose monitoring. Now, producing guidelines, looking at the evidence, and then making recommendations is really easy. I know it takes a lot of time and effort, but it's fairly easy. Implementing them, however, is a major challenge. And this challenge is because there is this significant implementation gap. And this implementation gap has quite a number of factors. There are clinician and patient factors, but there are also very significant resource and services impediments, the availability and access to the types of treatment that we need, and their costs and their impact on the overall health and country budget. And this gap is really wide in low and middle income countries. And it was the low and middle income countries that were really the focus of these clinical recommendations, because there's plenty of societies that have produced recommendations for high resource countries, but not so many that take into consideration low and middle income. And as an example of the challenges, and remember that IDF, the majority of countries who are IDF members are lower middle income countries, and that 80% of adults throughout the world live in lower middle income countries. And the challenges are really summarized in this study here, which was published a few years ago, a survey of 37,000 adults with diabetes living in 55 low and middle income countries. And you can see that the access to the sorts of things that we know are required for optimal care are very limited. Only 50% availability of glucose lowering medications, 40% antihypertensives, less than 10% access to statins, and then there's the counseling. And when you put it all together, only 5% of people living in these countries had access to all the resources that are required to implement clinical recommendations. And IDF can, through its lobbying, try and do something about these barriers to the implementation, but it can't obviously change all of them. But what it can do, and what it has tried to do, is to make recommendations and to modify the recommendations to try and take into account these resource limitations. So the approach that IDF used in putting together the clinical recommendations was to come up with two standards of care to recognize and acknowledge the diversity of the global healthcare systems and inherent resource constraints. So the recommendations were made on two levels. These two standards of care are optimal care, which sets the standards which all health systems should aim to achieve, and that all people with diabetes or at risk of diabetes should have access to. However, we know that that's not possible at the moment. And so there was a second level of recommendations, which were called basic care, which were the starting point, the foundational level of trying to get to optimal care and recognizing that even this is not currently possible in many countries throughout the world. So both standards of care are still founded on the four key pillars of diabetes management: education, lifestyle modification, monitoring, and reviewing, emphasizing the importance of early intensive glycemic control, which has actually been pushed back a little bit because of the advent of some of these new medications, the importance of early multifactorial risk factor intervention, and also, of course, using, where possible, some of these newer medications which have additional cardiorenal protection. So, as an example of the two standards of care, I think everybody would agree that measurement of HbA1c at regular intervals is the standard for assessing glycemic control. Of course, there are some situations where you can't accurately measure it in some individuals, but this is the standard method which we would all accept. However, as shown here by this survey of 160 countries done by the WHO, that measurement of HbA1c was only available in 50% of these countries' health facilities, and even then it was only available consistently 50% of the time. So measurement of HbA1c in many countries throughout the world is only accessible to about 1 in 4 people with diabetes. So if our recommendation was that everybody had to have measurement of HbA1c, then it would make them impractical. So in terms of basic care, this has been modified to the point that we still advocating the use of HbA1c at regular intervals to assess diabetes control, but it recognizes that if HbA1c assays are not available, then you can use or should use any available glucose measure that is there and can be done. So these guidelines have recommendations address 7 chapters, and I only really want to give you a flavour in the limited time we have available for 2 of these. First, First, let's think about it. First is I want to talk about cardiorenal protection, just to give you an example of what's there in these recommendations, and then secondly, I want to talk about detection of diabetes and intermediate hyperglycemia and prevention of type 2 diabetes, which leads into Professor Linon G's presentation. Now, seems to be, sorry, seem to be skipping a bit here. Sorry, let's go back. Okay. So if we start first with cardiorenal protection in type 2 diabetes, the key points in relation to, they all start off with key points, and this is summarized here. We know that cardiorenal complications, which include atherosclerotic cardiovascular disease, heart failure, and chronic kidney disease, are major drivers of premature morbidity and mortality. We know that they're highly prevalent. We know that some of the newer blood glucose lowering agents, SGLT2 inhibitors and GLP-1 receptors, have demonstrated additional cardiorenal benefits. And we also know that early and regular screening for CVD and CKD are critical for timely intervention. Now, then we turn to, in each of the chapters does the same, to the global consideration. And I've already mentioned the limitations with regard to HbA1c measurement, but there's another survey of 125 countries, and this was in relation to, of lower middle income countries, and this was in relation to assessment of chronic kidney disease. And here, again, only 1 in 4 facilities could routinely measure serum creatinine and or proteinuria, therefore making it quite difficult to actually assess the presence of CKD. So we also know that access to the new blood glucose lowering medications remain limited, although it is improving slightly in some lower middle income countries. But we also know that the WHO essential medicines list includes many medications which are very effective in managing cardiorenal risk, such as antihypertensives and also mineralocorticoids. And we know that you can still have a good effect, a significant effect in reducing cardiorenal risk, um, even if you don't have access to all the medications, especially the newer ones, which we know are beneficial. So just to give you an example again of these recommendations. So these are the recommendations that relate to atherosclerotic cardiovascular disease. There's essentially no difference in terms of the screening and risk assessment, but when deciding how to screen, these need to be locally adapted. There's no point trying to use a cardiovascular risk score, for example, that includes measurement of cholesterol if you can't measure cholesterol. In terms of the management, there are many similarities between optimal care and basic care, which can make a big difference to reducing atherosclerotic cardiovascular disease, glycemic control, risk factor control, blood pressure control. But then there's a difference when it comes to basic care, because I mentioned before that access to medications for lipid lowering are quite limited in many countries. And then there's the additional newer agents which one would use in optimal care. And things like SGLT2 inhibitor access is improving with the advent of generic medications, and this will get better over time, but it's still important to recognize that basic care can still achieve a lot. Similarly, when it comes to heart failure, again, a difference with regard to screening and risk assessment for heart failure. Not many countries around the world can routinely do echocardiography and don't have access to biomarkers, but still you can look for and screen for heart failure without necessarily using these agents, these methods. And again, the situation, as I mentioned previously with cardiovascular disease, is that you can still do a lot with basic care, even though you have more limited access to some of the medications. And then the situation with chronic kidney disease, again, you would ideally measure renal function and assess proteinuria. Again, this is not always possible, and if so, you have to have some local adaptations. And again, the interventions between the two, there's a lot of overlap, and you need to be able to use or better use whatever's locally available. And then as time goes by, we should actually have access to more in more and more countries to other agents such as the GLP-1 receptor agonists. So if we turn now to detection of diabetes and intermediate hyperglycemia and prevention of type 2 diabetes, what these guidelines and recommendations did not do, we did not review the diagnostic criteria for diabetes and intermediate hyperglycemia, and we accepted the two most currently used ones, those of the WHO and the American Diabetes Association. And I'm sure, as you're all aware, one of the things that's slightly problematic is that they do differ, especially not with regard to diabetes, because they're both entirely aligned when it comes to diabetes. But when it comes to intermediate hyperglycemia, the two guidelines use different levels of glucose for diagnosing impaired fasting glucose. The ADA uses HbA1c as one of its diagnostic criteria, whereas the World Health Organization has not finalized yet its recommendation with regard to intermediate hyperglycemia. So the key points when we're looking at diagnosis and screening is that we all know that 1 in 2 people around the world have undiagnosed diabetes, and we know if we screen and detect undiagnosed diabetes, then this actually increases the chance of delaying or preventing complications. We also know that detecting intermediate hyperglycemia is challenging. Impaired glucose tolerance can only currently be detected by doing a 2-hour oral glucose tolerance test, although we may soon also have a criterion widely adopted based on the 1-hour oral glucose tolerance test, but it still requires an oral glucose tolerance test. And again, we know that if we can identify people who have intermediate hyperglycemia, that they can benefit in terms of interventions to prevent type 2 diabetes. Now, in terms of the global considerations, I've already mentioned the restricted access to HbA1c testing, but this also applies from the WHO survey to oral glucose tolerance testing, where only 50% of countries, their health facilities are able to do an oral glucose tolerance test, and only half of those can do it consistently. So if we only had a guideline that said you've got to do either an oral glucose tolerance test or HbA1c, it wouldn't be applicable to many countries throughout the world. So therefore, if that is the situation, then measuring plasma glucose, even by finger prick testing, although not ideal, may be the only option for testing for possible diabetes and impaired hyperglycemia. So when it comes to screening options for diabetes and intermediate hyperglycemia, I think the important point, which I've emphasized before, is that it all has to be done taking into account local resources. So you locally have to determine who is going to be the target group. You have to determine which risk score you're going to use, and preferably one that is developed locally or adapted to local factors. And again, in terms of the blood tests that you can use, it depends what you have available. So if we just turn to type 2 diabetes prevention, we know that there are two basic strategies, the high-risk individual approach and the population approach. And we know from many randomized controlled trials that structured lifestyle modification programs are effective in preventing or delaying type 2 diabetes, but need to emphasize that the data all relates to impaired glucose tolerance, and it does not relate to ADA-defined impaired fasting glucose. We know from the many community programs that the design of these programs, the number of the interventions, whether they're given face-to-face or remotely, differ. And we also know that decisions to implement high-risk individual interventions need to be guided by local resources and what the health system capacity is and the cost that involved. Also, as an aside, which we're not going to discuss in any detail, the population approaches are also important to try and re-emphasize the need to reduce risk factors in the general population. But overall, encouragingly, there appears to be either a stabilization or decline in diabetes incidence in many high-income countries. So when it comes to the recommendations for prevention, we would normally expect that with optimal care, there would be some programs that would be there would be some diabetes prevention programs. With basic care, the first decision that needs to be made is whether the health system can actually cope with and implement a diabetes prevention program. Ideally, it would, but it may not be the highest priority, considering all the other things that are required to improve diabetes care. And of course, we also should pay some attention to diabetes prevention population strategies. So all this is summarized in this diagram, which Professor Linongji will talk more about, but it's basically for diabetes detection and prevention, it's all the same. Risk factor assessment, testing those people that are at high risk with whatever test you have available, and then if you discover diabetes, obviously treating it, and if you have intermediate hyperglycemia, trying to implement a diabetes prevention program, and then making sure that the individuals who are normal are reassessed, and that all of this hopefully is and ideally supported by a data system and evaluation. So in this brief presentation, I've tried to just give you an overview of these clinical practice recommendations. They aspire to encourage all health professionals and policymakers to consider and adapt the optimal care recommendations to their local health settings, and they do try and emphasize that as much that can be done in lower resource settings. These recommendations are iterative and they'll be updated, and that you can actually access them if you already haven't through the IDF website or through that reference there to diabetes research and clinical practice. So thank you very much for your attention.
Professor Ceriello.
Okay, thank you, Stephen. And now we move to Professor Linongji on the situation in Asia or Southwest. Please, Lino.
Hi, good afternoon, good morning, Linongji. I'm an endocrinologist from Peking University People's Hospital. Thank Professor Stephen Calaguri for his very nice introduction on the global guidelines recently developed by IDF. In his presentation, they really emphasize that globally there's a huge diversity in case of with regard to medical care system, social environment, as well as economic development. So really, even though we have a lot of very good data for diabetes prevention, but really the implementation of those clinical evidence need to be specific to the regional circumstances. So this is why the guideline consensus were developed, led by Professor Ramachandran and Professor Chialo, to to the region, that's the Southeast Asian population. So in that consensus, it's called for clinician-led diabetes prevention can start before national system catching up. So this is a consensus on how to implement the evidence-based guidelines in low and middle income countries. This is my disclosure. I have nothing to declare related to these CME activities. The learning objective is knowing the new guidelines for Southeast Asia primary prevention of intermediate hyperglycemic, which was just developed and published last year. And in this presentation, I'm going to focus on 3 concrete steps: screening, confirmation of intermediate hyperglycemic, and then develop personalized intervention strategies and actions to prevent intermediate hyperglycemic from developing type 2 diabetes. In the guideline, there's a discussion on the Southeast Asia diabetes prevention. It's known that we lack the evidence. We have ample evidence, not only from a global perspective, but also from regional studies. The gap really is the implementation problems, not the evidence problems, because in this region, like majority of people with in the adult population, they have abdominal obesity, for example, in the Indian adults. And also, if you look at their lifestyles, more than 45% of individuals, they are not adopting a healthy lifestyles, for example, the physical activities. And also, particularly in this region, there's a high prevalence of diabetes in young population. So instead of start screening at age 40 as recommended by in other populations, we really should start screening for pre-diabetes and diabetes as a younger age, like 30 years of age. The guideline simplified the complicated pathways procedures into 3 concrete steps or actions, which is first screening for a high-risk adults, either at risk for diabetes or at risk for intermediate hyperglycemic. And then the second step is to confirm intermediate hyperglycemic or diabetes. And then for those with pre-diabetes or intermediate hyperglycemic, to design and deliver evidence-based interventions to prevent them from developing diabetes. These 3 steps need to be tailored according to the settings be it in the clinical setting, in community setting, but more important is to the guideline emphasize the following up. It's not just you diagnose and then you give advice and then say goodbye to people that you are going to intervene for diabetes. The first step is to screen the high-risk individuals, and the guideline recommend for the screening purpose, you really can use the readily available information, which is either already exist in the medical record, or you can easily collect it from individuals that at risk for prediabetes or intermediate hyperglycemic. Many countries, including China, India, and Australia, had already developed screening risk scores. For example, this one developed by in the Asian Indians, using the information of aging, family history, diabetes, BMI, and these circumstances, and whether it's a sedentary lifestyles or so. If and then for each items, there's a score, and then if you add up the scores, that is add up to like 21 in the Asian Indians, that can trigger the laboratory test for confirming whether these high risk individuals have hyperglycemic or not. So that's the first step, emphasizing the tools available for non-invasive risk classification, and then if for those with higher risk, so you start with a second step, which is laboratory-based diagnosis or so this using the criteria as Professor Caligori has mentioned, the fasting glucose, post 2-hour postprandial glucose, or HbA1c, and then recently IDF also has recommended to use 1 hour post challenge glucose levels. For example, this is 150 milligrams per deciliter for identify those with or identify and diagnose those with intermediate hyperglycemic or pre-diabetes. So so next step, once the individuals were identified or diagnosed as intermediate hyperglycemic or pre-diabetes, the concrete step need to be designed based on the individual the phenotype. For example, some individuals will have isolated impaired fasting glucose or isolated postprandial impaired postprandial glucose, but some will have a combination of the two. And then depends on the phenotype, you need to start with lifestyle modifications, basically the diet and then the exercise. And then depends on the resources available or interventional settings, you can choose how to deliver the interventions, be it face-to-face, individual counseling or group counseling, or SMS based messaging, because all these were proved to be efficacious in preventing diabetes. And then if there's a need, for example, if all these lifestyle intervention were implemented, but still there's no effect on preventing diabetes. The medication that has been proved to be safe and effective, such as metformin and alpha GI, could be used in combination with existing health style interventions. So the guideline really emphasize that the counseling need to be turned into a concrete actions, which is not only the just advice, but to tell the people with the pre-diabetes, intermediate hyperglycemic, on what exactly they can do in terms of dietary control and exercise, and most importantly is to the follow up to see whether the recommendations that you made could be implemented, could be materialized by those people with pre-diabetes. And if there's a need for a medication indication, or for example, metformin or alpha GIs, it can be aided on a timely manner. Don't just watching, but not taking actions. Yeah, from South Southeast Asian population, there are many studies, nice studies showing that the different way of deliver interventions actually work. For example, the SMS messaging interventions, lifestyle plus metformin interventions, and they are also to be efficacious in preventing prediabetes from developing diabetes. So really, the physicians need to choose those interventional strategies or combining them depends on individuals' circumstances, and also the resources availability to design individualized interventions. So in Southeast Asia, there's a huge population with pre-diabetes. For example, in India and China, about from 30% to like 50% of adult population could be classified as pre-diabetes. So the fundamental way of reducing the pre-diabetes and prevent pre-diabetes to diabetes is through social changes, because the social economic environment make changing the lifestyle of individuals. So, but we could not wait until that happened. We should facing the individuals in front of us, in our office, in our community, to take actions, but not just waiting for the whole environment changes. Because those barriers cannot be solved overnight, but we cannot just wait. We should take actions to people that in front of us as a clinician. So I think this call for action is really have some urgency that instead of waiting for like social catching up, we really should start the intervention immediately. Thank you very much for the attention.
Thank you, Stevens. Thank you, Linon. We have time for short debate, waiting for questions. You are still waiting for some questions, but Stephen, I think that it is the case to clarify the concept of intermediate hyperglycemia, because I believe that many people are still not aware about why WHO decided to change the definition of prediabetes.
Yes, I don't know that. I'm not quite sure. I mean, by changing the definition, I mean it was the ADA that changed their definition of impaired fasting glucose to lower the lower level, and WHO decided to stick to the 6.1 to 6.9. There was a consultation with regard to HbA1c, and unfortunately, it happened just before COVID, and a decision was going to be made. I can't tell you what the decision. They were going to have an HbA1c range, but it just got delayed, and now they're looking at revisiting it. So I think that they will come up with an HbA1c measurement for intermediate hyperglycemia. I mean, as you know, there's the biggest issue at the moment is what to do with 1 hour plasma glucose, and I know that obviously IDF has made a statement, and there's a Lancet commission that's looking at all of this. And it probably will be added officially at some stage. But again, WHO doesn't have any immediate plans to do this. And I've got to say that it's partly related to what's happened to their funding base. So I think that it was just a set of global circumstances that have led to this current situation I don't think they're going to change the the fasting glucose level. They will add HbA1c, and I'm not sure what's going to happen with 1 hour glucose.
Thank you. Linon, I have, my opinion, quite strange question, but let's, is the only one we got at the moment. What is more important to control, glycemia or blood pressure?
Yeah, I think there's a very strong clinical evidence showing that by controlling hyperglycemic hypertension, you can not only reduce the risk of microvascular complications, but also macrovascular complications such as coronary artery disease. And the data from China, from Daqing studies, show you that this intervention on prediabetes not only can reduce the risk of developing diabetes in like after like 25 years or 30 years, and also can reduce the risk of diabetes, microvascular complications such as retinopathy, and also the cardiovascular disease. Recently, even long-term follow-up observed that those who are receiving interventions, they actually carry a lower risk of mortality. But this is really a long-term outcomes. So early intervention do work. I think similar data were also available for supporting the antihypertensive interventions for reducing cardiovascular risk.
Thank you. Steven, I think that it would be nice to underline that these guidelines are for the first time recommending the possibility to start immediately with the combination. But of course, we were not showing this chapter on glucose control, but I think that also this is a key recommendation in this guidance. What is your opinion?
Yeah, obviously the guidelines cover a lot of topics, and I can only just give a sort of brief overview. And I would obviously encourage people to have a look at those because a lot of work went into it by a lot of people. And sure, it included the possibility of initial combination therapy. There are some studies which have looked at this, but I think that increasingly we may see that as a means of achieving diabetes control quicker and maintaining it for longer before you get a secondary failure to these agents and have to introduce a third one. Again, I mean, it will depend on what's available, resources that are available, their cost, etc. So they have to be adapted for local resources, but certainly it is an approach which we're likely to see. And, in time, when these newer medications are cheaper and more widely accessible, they may be an ideal combination to start off with.
The very quick answer to this question, please, because of the time is flying. There is a colleague from Peru who is asking, if I have 1 hour value of glucose, 155 milligram deciliter, and stage 1 diabetes, could I use SGLT2 inhibitor?
I don't think now we have data to support using SGLT2 in that particular individuals. So we don't have there's study in China showing that SGLT2 treatment can improve the chance of remission of diabetes from diabetes stage to normal glycemic, but there's no SGLT2 based intervention. Yeah, so far.
Thank you. So may I have the closing the slides, please? So first of all, do not forget that to fill in the participant evaluation form at the end of this webinar, in order also to receive the certificate by email. This webinar is also available on demand. The recorded, sorry, the webinar will be available starting from June 4th on the Medea e-learning platform. The credits, CMA credits, are available on the on-demand sessions until November 28th of this year. I will remember that these activities are planned all during the year, because we have just the live webinar, which is also available on the website of Medea. And then we will have a couple of podcasts and a video interview to complete the approach to this topic. You also can follow up on social, so if you are use them, you can find almost in any. And let me thank first of all our speakers and Medea for the wonderful organization, Merck for supporting this program, and all of you who were with us in this today for this webinar. So thank you very much and have a good day, good evening. It depends when you come.
Thank you. Bye.